since November, and it is changing now in January, and we now have to pay attention. And this morning I've called the population to this conversation with you, the media, for some paying of attention. I wouldn't say much more because we have some excellent information packages from the people that you're familiar with. This morning I have with me CMO, Dr. Roshan Parasham. We have statistician, Dr. Heinz Zudas. We have Dr. Carrington, the virologist, Professor Carrington, who is the person who is taking us through from day one on monitoring the behavior of the virus as it changes from one form to another as the virus tries to survive, because we are now in a post-vaccination period and the virus knows that and is trying to respond to it by us trying to get rid of it. It is trying to survive, and that's where the variant is coming. And of course we have Dr. Myron Richards, who will tell us about our hospitals with respect to our preparations, our situations, and between these four officers. And Dr. Trotman is here with us way down there. So this morning we're going to hear from the 5 experts in public health in Trinidad and Tobago, led by the chief, Dr. Roshan Parasham. Dr. Parasham, take us through, please.
Hi, good morning. Thank you, Honorable Prime Minister. Good morning to the Honorable Ministers, colleagues, members of the media, members of the viewing and listening public. So we begin as usual with the dashboard, but the dashboard, as you know, has changed. We have reverted to a weekly schedule as opposed to a daily schedule. So starting on the top, fully vaccinated, 51.3%. I think the Honorable Minister will go into further detail later on. So new positive cases between the period January 2nd to January 9th, which is accounting for 7 days, 406, giving us a rolling 7-day average of new positive cases, 58. Deaths reported during the period 8, just above an average of 1 per day. Total active positive cases during that period, 206. So the numbers of active cases refer to the cases that are in the community being managed by the CMOH officers, various officers across Trinidad and Tobago. Total patients hospitalized, 47 in hospital and step down within the parallel healthcare system. Dr. Richards will expound on that and give us some further details as how we'll be classifying it going forward. In terms of the deaths, remaining at 4,297, which represents, and I asked Dr. Heinz to put this little bit in on the right-hand side, a risk reduction among vaccinated persons of 92.2%. Simply put, it means that the chance of dying, having contracted COVID in a vaccinated person versus a non-vaccinated person is 92.2% less likely. So to give you an idea, the vaccines have been holding up in terms of death and hospitalization across the period of 3 years in Trinidad and Tobago, specific to our type of vaccines. So Dr. Heinz will be going into the epidemiological update, and in one of his epicurves, he will highlight where the variants of concern, as well as their sublineages, will have entered Trinidad and Tobago and been first detected. Then Professor Carrington will go into further detail about the sublineages, their characteristics, and what to expect with them. And Dr. Richards will go into the hospital occupancy level to show you where we are in terms of our level of comfort, in terms of number of patients, and what kind of capacity we have there. So Dr. Heinz, if you could take over, please.
Thank you, CMO. Honorable Prime Minister, Honorable Ministers, members of the media, members of the viewing and listening public, colleagues, good morning. Today we'll go quickly through the update. We haven't gone through it in this format in some time. This is with data as at yesterday, that's the 11th of January 2023. The last thing that CMO spoke about is the first thing that we'll point out here, and this is the epicurve that has gone from July 2020 all the way across to the end of 2022. Really just illustrating two things: the different colors representing different months. We try to match colors to months from one year to the next, so that you see similar colors representing the same month in 2021 and 2022. And the heights of the bars, of course, representing numbers of cases showing up on a daily basis. What we're emphasizing with this today is those arrows and notations above them. We start all the way over on the left, and we see that in August we had that B.1.111 variant that sort of predominated throughout 2020. We saw Gamma in February, and that's the Gamma variant of concern. At the end of July or thereabouts, we first detected a first case, confirmed case of the Delta variant, and that led to a severe spike in both numbers of cases and severity of cases. So we had the peak in both numbers of cases and numbers of fatalities at that point in time. As we entered December, we also had the introduction of that Omicron group of variants. And we've had just about all of the ones that have been of interest and concern. We've had detections throughout the time period between December 2021 and December 2022. So the BA1 we saw around December 11th, BA2 January 30th, 2022. A little bit of a, I don't want to say a break, but a lull. Around June, we noticed both BA4 and BA5, June into July. And then these are sublineages of the BA5 Omicron variant that we also saw pop up in our population. Subsequent to that, the BQ1, the XBB 1.5, the BF7, and there's also another sublineage of BA2, which showed up in September. So we have seen all of these. They have made their debut in the population, and we have seen in some cases that introduction of some of them would lead to a little bit of a spike or a hump in the data, because some of them can reinfect, some of them infect more quickly and have what they call a transmission advantage. So you saw those things play themselves out in the population. But against that backdrop, we also saw that from September through to the end of the year, we had decreasing numbers of cases. And as we moved from November, which was our lowest, into December, let's look at the weekly data to get a better idea of what's going on here. As we move from November into December, what we see is the lowest numbers in that dark green section over to the right-hand side, which is November. The red is December of 2022, where those bars start to get a little higher. And then the first 2 weeks, because we're only 2 weeks into 2023, the green bars represent the weeks in January. Bearing in mind that we are on day 3, completed day 3 of the second week in January, and yet that bar is almost as high already as the first week. So we are seeing an upward trend in those numbers of cases from week to week. I'll show you the actual figures in the next slide. But we're also seeing an increase in what we call the positivity, percentage of patients tested and turning out to be positive for COVID-19. So you see both of those in this slide. This slide shows the epi weeks on the left. It shows the dates, both at the start and the end of the week, so you know which month we're in. So we're starting essentially at the end of October, start of November. And if we look at the numbers of cases on a weekly basis, we saw those rise from low hundreds, 118, 119, through to 150s. And as we got to end of December into January, we're now seeing 204, 338. So we are seeing increases in those weekly totals. If we look at the last two cells on the right-hand side, the ones that are in red, we notice that from week 50 to 51, or rather 51 to 52, that is from the week that ended on Christmas Eve to the week that ended on New Year's Eve, there was a 38% increase in the weekly total. And then the following week, that first week of January, that completed week was 65% higher than that. So we are seeing a pick-up, an uptick in the speed at which the weekly totals are increasing. So that's something that we're bearing in mind, and we know that it is, to some extent, driven by all of the gathering and mingling that we would have done, and we note that it will be driven further by the gathering and mingling that we plan to do. So we do need to, at this point, put out some cautionary advice in terms of bearing in mind the presence and the potential for spread for this virus that has not left the population. If we look at the positivities, we see that 5.3% was sort of mid-November, 4.3 was start of November, we're up to 18.6, so that positivity has also gone up correspondingly. That's the only slide I really belabor. This is the monthly data, shows the same thing at a monthly aggregate. Then we have the overall demographics for the positives, which really hasn't changed. We still have a slight female preponderance, majority in that 25 to 49 year age group. And with the deaths, a little bit of a reversal. slight male preponderance, and the majority of them, more than 2/3 of them, being over 60. The point I want to emphasize here with the deaths is that we note that those who have comorbidities and those who have not been vaccinated are the ones that predominate among these fatalities. So if you know you have comorbidities, you know you haven't been vaccinated, or you know that you have been vaccinated and are due for your booster, we again always strongly recommend that you go and you get your vaccination, because we have seen from our own data that the vaccination reduces the risk of death by about 92%. So with that, I bring my bit of this to a close and turn over to Professor Carrington to give more detail on the variants.
Okay, good morning, everyone, and greetings to the Honorable Prime Minister, the Honorable Ministers, the members of the media, members of the viewing and listening public, and my colleagues here today. So I'm just going to tell you a bit more about the Omicron, the lineages that have arisen from the Omicron variant, and what they look like and what we expect of them. So, as we've heard, the Omicron variant of concern is the dominant SARS-CoV-2 variant globally, and it has evolved, and it's also the dominant one in Trinidad and Tobago since early 2022. During the time it's been around, it has evolved to give rise to 650 new lineages, so there's a lot of lineages circulating around the world. And all of these lineages, though, remain classified as part of this Omicron complex, so they're all considered Omicron, and they're referred to as Omicron subvariants. Now, we first detected, as I said, we first detected Omicron in Trinidad and Tobago in December 2021, and it's been dominant since early 2022. To date, of all those subvariants that have been circulating around the world, we have detected 68 in Trinidad at different times and at different levels. And of those subvariants, there are some of them that are classified as Omicron subvariants under monitoring by the WHO. They get that classification because they show signals, and not confirmed, but they show signals of spreading more quickly, and they have mutations that are either known to or suspected to confer changes in their epidemiology and to give them some sort of fitness advantage over the other ones. So those are the ones that we monitor, the Omicron subvariants under monitoring. We have detected 6 of them, as we've heard, in Trinidad and Tobago. We have BA5.2, BA4.6, BF7, BA2.75, BQ1, and XBB 1.5. So we've seen all of these. So if I could get my slide. So this slide basically shows the information on the 6 Omicron subvariants under monitoring that we've detected in samples that were sent for sequencing in Trinidad and Tobago up to January 2023, and I'm showing data from June 2022 onward. I first want to draw your attention to, the first one I'll draw your attention to is BF7, and it appears in pink in the diagram, and it has been reported in about 95 other countries. We have detected it in 6 samples in Trinidad and Tobago, with the earliest sample being in August 2022. Now, based on genomic sequencing, so I've said it's been seen in many countries, 95 countries for quite a while. And based on genomic sequencing of recent samples collected in China, this variant, BF7, together with the one called BA5.2, they account for 97.5% of the locally acquired cases there. But it's found elsewhere, and as we've seen it in Trinidad as well. The BA5.2 has been seen in about 146 countries to date. It was first detected in Trinidad in June 2022, as Dr. Hines showed. We saw it in about 350 samples, and in this graph, those are represented by the darker green, and they were associated, as he said, with a sort of hump in the cases in July and October. So we had a wave of infections there. So the next one I want to draw attention to is BQ.1. This has been found in at least 87 countries to date. We have detected it in 42 samples in Trinidad and Tobago since last October, and they are highlighted in the light blue. And although the total number of samples that we've detected are low, we did notice a sort of increase, a rapid increase in the prevalence of BQ1 during November and December. Okay. And then finally, I'll turn to XBB.1.5. That variant, it has now been reported in 38 countries to date. Over 80% of the sequences that have been derived from samples are from the United States. Okay, so it's mainly in the United States. We detected in Trinidad in 4 samples so far, and those are shown in dark blue, so they're quite recent, with the first detection was on December the 10th, a sample collected on December the 10th. Now, the samples that we received for sequencing, they are not randomly sampled, and they may not therefore be representative of the whole of the Trinidad and Tobago population. However, the increase that we saw in BQ1 and the appearance of XBB, both of those events are consistent with global trends. In the US, XBB 1.5 very quickly replaced the other subvariants, including that BQ1. And there has been a lot of media attention and speculation about this subvariant. Now, the WHO has analyzed all the data to date, and their most recent risk assessment was published today. And basically, based on the genetic characteristics and the early data, early growth rate estimates, they have concluded that XBB 1.5 may contribute to increases in case incidence globally. However, since that data, those estimates, are coming from only one country, they came from the US, their overall confidence in this estimate is relatively low. And what we need is we have to get more data available from additional countries for that assessment to be reevaluated, and they'll be doing that. Now, the available data indicate also that XBB variants are the most antibody-resistant variants to date. What that means is that they are less sensitive in laboratory tests. They are less sensitive to antibodies produced by the vaccines and the various and previous infections. However, it is important to note that this assessment is based entirely on laboratory experiments. And while the results suggest that XBB 1.5 is likely to be associated with more reinfections and perhaps more breakthrough infections, this data says nothing about the real-world effectiveness of vaccines against XBB 1.5. So you cannot take data that says they're less easily neutralized by antibodies and conclude that the vaccines aren't working. All right? The antibody response is just a small part of the immune response that we have. So the immune response consists of more than just the antibodies that block infection, and the experience to date with other antibody-resistant variants is that the vaccines continue to be very effective against severe disease and death. And we've seen it from our own data that the vaccines have been, we have 92%, I think he said, risk reduction. And this is against a backdrop of a whole bunch of variants, very different from the original one that the vaccines were developed against. So vaccines are still working around the world. Now, there's no current data to say whether XBB 1.5 causes more severe disease than other variants. Severity assessments are ongoing, but it is worth noting that XBB 1.5 doesn't carry any mutations that we know to date are associated with a potential change in severity. And the WHO's rapid risk assessment, as I said, is based on currently available data, currently available evidence, and it will be revised regularly as more evidence and data come to light. Thank you.
Good morning to the Honorable Prime Minister and to the Honorable Ministers of Health, Energy and Energy Industries, Office of the Prime Minister, and National Security. A special good morning to all our media counterparts who are joining us here today, and to each and every one of you who is viewing and has sought interest in our discussion and conversation this morning. I hope that 2023 is treating each and every one of you kindly so far, and we continue to all be safe. This morning, I would like to share some information on the Ministry of Health's continued response to the COVID-19 pandemic, especially given the recent global changes that we would have noted. I'll also provide some statistics and some trends in terms of the demand and the capacity for hospital care, as well as clinical characteristics. And lastly, but most importantly, a couple of gentle reminders to all of us on mitigating or reducing the negative impact of COVID-19, especially as we enter the much anticipated Carnival 2023 season. So I'll start this morning with a discussion of where we are at in the parallel healthcare system, and just to mention a couple of transitions that we have been making since we would have last met here. So the parallel healthcare system continues to be in operation, but as per policy directive from the Honourable Minister of Health, we had started a process of transitioning the parallel healthcare system. That is, we have built-in capacity within the individual RHAs or within the traditional healthcare system to manage COVID-19 cases under strict guidelines for infection prevention and control. So there is capacity within the parallel healthcare system, as you all would have known, and we would have discussed extensively. And now there is new capacity in what we would term a hybrid system within the RHAs. And these changes will be brought across in next week's weekly media release. I'd also like to share some information now, moving on, about the number of cases and the demand for care. Dr. Hines would have indicated that as of December, we would have noticed an increase in the confirmed seven-day rolling average of confirmed cases, and this inevitably leads to an increase in the demand for hospital beds. And this graph demonstrates, if we look at the bottom line here with the orange bars, demonstrates that there has been an increased demand for hospital care and hospital beds over the last month. And this really coincides with that increase in cases. Specifically, we have noted that increase from December the 8th, and it has been consistent on a daily basis. So for just over 1 month now, there has been an increased demand for care. I'd like to now draw your attention to the actual number of COVID-19 patients in the 9 hospitals in the parallel healthcare system and in the now hybrid system. And as of 8 a.m. this morning, there were 71 COVID-19 patients being treated in the public health system. 50 of those patients are in the parallel healthcare system, while 21 are in the hybrid system. Now, when we look at that 71, there are 5 of those patients that require ICU level care, and there are 2 pediatric cases within that 71. And I'd just like to draw a distinction here in how we have been classifying these cases on the basis of what we term primary and incidental COVID-19 cases. So we have found that some of the cases that present are what we would call primary cases. Primary cases are those persons who present with symptoms of COVID-19. So they would come into the accident and emergency via the ambulance with fever, shortness of breath, and a cough. Incidental COVID-19 cases are those persons who present for a non-COVID complaint. It could be a diabetic foot, it could be a car accident or congestive cardiac failure, or some complication of a comorbidity, but on arriving at the hospital and being tested, they are found to be COVID-19 positive and then require care in that area. So we have, as I said, 71 patients this morning. Just for a matter of context, in November of this year, the average number of patients, COVID-19 patients per day was 20. So you can well appreciate that the numbers are increasing. But I would like to reassure the public that the capacity is there within the parallel healthcare system and now within the hybrid system, and that we are monitoring trends in terms of occupancy, in terms of the clinical nature and clinical status of these patients on a daily basis to ensure that the relevant reallocation of resources or expansion of services can occur. And this is done proactively. This graph just shows the breakdown in terms of the levels of care. At this point in time, we have no step-down level patients. All patients are either at the ward level or ICU level, with, of course, the significant majority being ward level patients. The accident and emergency department is another area that we pay significant attention to as a measure of capacity and to understand the expected need for beds, and by and large, the accident and emergency departments have had low numbers of COVID-19 patients requiring care. But what we've noticed are that the ones who do access and do come to the accident and emergency department end up being hospitalized. So it's a different clinical picture than what we would have seen in December of 2021, when we had on average 200 patients on some days across our accident and emergency departments. The total number of patients this morning at 8 o'clock waiting transfer into the system was 6. So again, there is capacity within the accident and emergency departments in the parallel healthcare system. Our ambulance service continues to document and record low levels of usage for COVID-19. On average, the 7-day rolling average for ambulance usage is 7% and has been in that region from about November to present. So again, there is capacity within the ambulance transport service. As I close this off this morning, I'd just like to recap on a couple points. Firstly, we are seeing an increased demand for hospital care, and that is in alignment with the increase in the confirmed number of COVID-19 cases. Secondly, we have noted that 90% of those patients that are in hospital are not fully vaccinated and have significant comorbidities. Thirdly, we are seeing a balance now of incidental patients as well as primary COVID-19 cases in a ratio of 50-50. So half of the patients are incidental and half are primary COVID-19 cases. Fourthly, the Ministry of Health continues to monitor the trends on a daily basis, and we can upscale our capacity in a proactive manner, as we have been doing. Now, all of these factors combined really serve to remind each and every one of us about the importance of the public health measures and the identified World Health Organization recommended public health measures in reducing the negative impact of COVID-19. We have Carnival 2023 amongst us, and we all need to be personally responsible and to ensure that we take the best measures that are present and that are evidence-based to protect ourselves and the vulnerable persons around us, the elderly, the persons with comorbidities, and young children. It is only if we work together and all collectively exercise personal responsibility that we can move forward and have a safe Carnival 2023. Thank you very much, Prime Minister.
Thank you very much, Dr. Richards. Before we come back to the Minister, I'd just like to hear from Dr. Trotman about what's actually happening on the wards with respect to those who are seeking care, having been confirmed as COVID patients.
Thank you, Honorable Prime Minister. All protocols observed to the healthcare workers, I speak directly to you in your continued fight, our continued fight against COVID-19. I thank you, and I wish all of you and the nation a very happy and prosperous New Year. The climate that we are seeing in Trinidad and Tobago reflects patients, unfortunately, who are elderly, who have underlying conditions that we call comorbidities. They include diseases like hypertension or high blood pressure, diabetes, underlying cancers, etc. We are also seeing the bulk of our patients, and I speak to the nation from my heart, who are either not vaccinated at all, partially vaccinated, or not boosted with their vaccinations. These patients are opting to stay home until they are quite ill before presenting for care, and when they do present for care, fit the criteria for admission. When we see the younger subset of patients, again, it is in patients who have comorbidities or did not realize that they have comorbidities. So that is a trend throughout. The good news is we know that if you are vaccinated and you do come, you end up exiting the hospital a lot faster. And we also do know that if you are vaccinated and you for some reason end up sick enough to go into ICU, then those who are vaccinated have a much higher chance of exiting the ICU alive. The message is clear. To avoid the disease, we have to be together. We have to be in a position where we can transmit, namely touching and without our masks. And we also have to be unvaccinated and most times without or with comorbidities. I want to touch briefly on the pediatric population because that one always hits our hearts. We do have children still being infected with COVID-19, and for the most part, almost 100% of the times, their parents are unvaccinated. Again, I stress to the nation that the public health measures, we've been here before, they have worked before. They continue to work across the world. Let us then also not forget to wear our masks when we can, watch our distance, and always wash our hands. We are also within the flu season, and all of these measures will help with the flu. We want you to get vaccinated for the flu, and we want you to get vaccinated and boosted for COVID-19. Thank you.
Thank you very much, Dr. Trotman. At this time, I'd like to ask the Minister to give us his perspective on the situation, as you have heard, and as the Ministry is aware and is working on.
Thank you. Thank you very much, Honorable Prime Minister, fellow Cabinet colleagues, members of the medical team, members of the media, ladies and gentlemen, good morning and Happy New Year to each and every one of you. And may 2023 see us in a better place than we did for last year as far as COVID is concerned. I just want to jump off from Dr. Richards' presentation in which he indicated there is room in the healthcare system. I want to say, whilst there is room, we do not want to use that room. We do not want patients coming in who are ill and who are unvaccinated. And that is why we took a decision last year in November to launch this mall drive for vaccinations, which started last weekend. We are concerned not only about COVID. The current vaccination drive is targeted against persons who are not vaccinated against both COVID and influenza, because both viruses have the capacity to overwhelm any healthcare system, as they are currently doing in colder climates where the viruses transmit more easily, or people are driven indoors because of cold and they are more likely to be closer together and so on. So we know that at this time of the year, our relatives and friends come in for Carnival, and that's why in November last year we took the decision to launch the COVID and influenza drive. Last weekend we started the first mall activity, and out of that, surprisingly, and I thank the population who came out, and let me thank the mall owners at this point in time. I really want to sincerely thank the mall owners for giving us access to their properties. It has proven to be a great success. So last week, over Friday and Saturday at the different malls, we did just over 500 COVID vaccines, which is very, very good. Whether it's first dose, second dose, or boosters, it far exceeded our expectations. And we did over 1,500 flu vaccines. So we did just over 2,000 in 2 days. And we are very grateful for that response. We will be back in the malls again, and we have advertised it, every weekend from now until February. And we ask persons to make use of this free, convenient method of getting vaccinated against both COVID and influenza. In addition, we never stopped vaccinating at health centers. So if you prefer to go to a health center, please do so. There are over 100 health centers, and now we are in certain malls. Let me give you the flu vaccine figures to date. In all, we have administered 29,962. Bear in mind, last season's flu drive, we did 26,000. So in just about 2 months, we have surpassed last season's flu drive, which is good. However, the disappointing news is only 452 children under 5 have been vaccinated, and that is one of the susceptible subpopulations for influenza. Only 383 pregnant women have been vaccinated against influenza. And every year we have the struggles of getting our pregnant women to be vaccinated, and we continue to work with them in our antenatal clinics. And a third category is always healthcare workers. Only 867 have been vaccinated against influenza. So those are 3 subpopulations out of this 29,962 that I personally are concerned about. In an effort to reach people, we have engaged TSTT. Some of you all who have TSTT numbers may have seen a message blast coming out to you. We hope to get the Digicel network to do the same. We have the ticker tapes running on news programs. And we have engaged the RHAs to call out individually, manually, individually, people on their databases who receive vaccines. So we are going all out in our communication drive and our distribution drive for influenza. On the COVID-19 front, to date, we have vaccinated 718,230 persons completely, which is 51.3% of the population, and 169,955 who have been boosted. We are again appealing, and let me repeat what all the doctors have said. The evidence clearly shows that vaccination works. Yeah. And what we are going to do, we'll ask Dr. Parasram to come in and talk about the booster program and the intervals between your primary shots and your secondary shots. But boosters around the world and vaccinations in general, regardless of whether it's any WHO-approved brand, Moderna, Pfizer, Sinopharm, J&J, whatever, they work. And our local experience bears that out. Prime Minister, with your approval, I would like to share with the population, again, some data. I would have taken a cabinet note, well, a note to cabinet in May of 2022. And in that note, I spoke about a seroprevalence study. I want to share again, because it didn't catch on in the public domain. The seroprevalence study was taking randomized blood samples. The total number of samples collected, whether you are vaccinated or unvaccinated, so 961 samples in a population of 1.4 million, is significant. Of those 961 samples, 12 were discarded for some reason. So we had useful samples of 949. Of that 949, 50 were non-reactive. That is, they did not demonstrate detectable levels of antibodies against COVID-19. So that is 5.27% were unreactive. But the good news is that 94.73 were in fact reactive. So it shows that out of the 949 samples chosen at random, reflecting vaccinated, unvaccinated, 94.73% of those samples showed a detectable level of COVID-19 vaccines. This is, again, scientific evidence quantitative evidence that there's a high level of immunity in the public, whether it's via vaccination or naturally acquired immunity through infection. So when we say we are comfortable with the level of immunity, this is the evidence that we rely on. So all the vaccines we have been using in Trinidad and Tobago, whether it's Pfizer, whether it's Sinopharm, whether it's J&J, are all captured in this data. You have heard every single health professional speak about the fact that people presenting to us are mainly the unvaccinated. So I will close by just adding my support to my colleagues' exhaustions to get vaccinated. Thank you very much, Honorable Prime Minister.
Before I come to the media, I'm sure you all have a number of questions. I just want to make a couple of summary comments, and that is what you have just heard is a synopsis of the situation in Trinidad and Tobago with respect to the population and its immune response to a variety of COVID variants. And the first question is, what are we doing about the increases elsewhere in the world where some people, some governments have been forced to react with some of the restrictions that we had been accustomed to early on? And the answer to that is that outside of the basic, and if I may label it that way, outside of the basic Dr. Trotman's exhortations as to what to do, the things we know what to do about the virus that's still around, the situation in Trinidad and Tobago at this time does not warrant an intervention outside of those basic provisions. However, you would have seen from the data presented by Dr. Hines that we are facing the prospect of increases in terms of infection levels. And you would have heard from Professor Carlton that we do have in Trinidad and Tobago, as usual, everything that exists outside in the wider world. We are therefore not approaching this phase of our existence in the pandemic by trying to shut out the virus, which is already with us. We in Trinidad and Tobago have discovered in our population all the variants of concern to us. And of course, the one that is causing most of the problems in the United States is already here with us. So when people ask, are we going to close the border or so, that is not a necessary response at this time. Our response has to be to suppress the spread of what we have amongst us. But again, when we look at how COVID has been managed by some countries, not all countries manage COVID the same way. Some countries, well, all of us in the beginning, tried to shut the virus out or slow down or suppress its entry and spread in the population. That was required at that time, and it still is required to not increase infection unnecessarily. But we did so at great expense to ourselves in other ways and all the things we did. And we were very happy to get to a point where we can, with some element of confidence, say that those drastic actions are now not required, because now we are dealing with a highly immune population. That immunity having been obtained, one, by a vaccination program where we very quickly, over a short period of time, introduced the virus into bodies and got the bodies to respond. And of course, roughly half of the population was not vaccinated by human hand. But the data shows that a large portion of that unvaccinated population did in fact get itself exposed to the virus, and we are now talking about a population in 2023 January that we think 92% had been exposed to an endemic virus, and therefore we're not in the same situation that we were in 2020 January or March or so on, where we had a virgin population and a rampaging virus which was causing great distress. That means that our exhortations that we have to learn to live with the virus is happening, but it's happening to a population that is in a better position to respond to the dominant variant at this point in time. It is quite possible that because the virus is existing and still mutating, that somewhere down the road, another variant can come up that can have characteristics that will cause us to have to think differently. But as of now, given the nature of the population, given the immune response that we've had, given the suppressing effect of the vaccine program and the natural immunity that we have built up, we are now facing a situation where we can continue to operate without the level of fear and distancing that we did before, which caused us to close our border, shut down our schools and so on. Those things are not necessary at this time. What is necessary is for the most vulnerable of the population, which remains very exposed and very vulnerable to all variants, to pay attention at the personal level to the protocols that Dr. Trotman talks about. If you know that you have that common phrase, we talk about comorbidities. If you know, and I would like to ask Dr. Parson in a little while to come back up and go through the list of what these comorbidities are, and many people have them and don't know, because they think that, well, some people have them and they think it's normal. It's not normal to be suffering from high blood pressure, but there are high levels of instances in this country. If you are, one of the things, that's a simple thing that the statistics have shown, and if you are obese, many people who are overweight did not perform as well as other people. If you have cardiac or renal kinds of concerns, and of course thoracic and pulmonary problems, if those are your personal situations, this alert is for you, and especially if you are in the cohort of 65 and over, because the record now going into our 4th year has shown that these are the areas of greatest grief. Now in Trinidad and Tobago, we've got through Christmas, and remember one time in the middle of the pandemic we went through an Easter when everybody was a doctor and everybody was an expert and a Google expert and so on. We went through that. Thankfully we're not there. But we are going into a carnival where the nature of carnival is meeting and mixing. We do not believe that the situation warrants us to not have carnival, but we believe that it warrants us taking personal decisions about your exposure to minimize instances of requirement for healthcare delivery to you. Many people, as we have seen, would have been infected and probably would get infected going forward and not respond in a way requiring healthcare delivery to such a person. Those persons are the largest number of people in the population living and responding to the virus. But there is that smaller population to whom the virus is still a very dangerous threat. So when we end this press conference, I will end on the note of asking the minister to indicate what are the requests we're making of the population. I might do it myself, as a matter of fact, because if I ask the minister, he might think. However, I would like to ask Dr. Parson to spend a couple of minutes telling the population about the comorbidity exposure and what is required to respond, because we are continuing our holding the line in some maintenance of the normalcy in Trinidad and Tobago.
Thank you, Honorable Prime Minister. So I think you said most of them already.
But I
so
would
persons
from you.
Okay, sure. So persons over 60 or 65 in some areas certainly are considered higher risk with or without comorbidities. Those comorbidities that we have seen affect, especially with COVID-19, are diabetes, mellitus, hypertension, asthma, and other respiratory illnesses. Cancer, Dr. Trotman mentioned cancer. We are seeing a lot of patients who are on chemotherapy, for example, or radiotherapy, those persons being affected adversely. Children, very small children, we're seeing those as well, particularly under the age of about 2 years of age. Those children also with their own comorbidities, for example, having developmental, being born with cardiac disease or some other illnesses. Those are your main group of people that we have seen come to us in terms of comorbidities developing severe manifestations of COVID-19 and other respiratory illnesses over the 3-year period that we had COVID with us so far. In terms of the booster campaign, I've been asked to just delineate the timelines again, which is on our website. So it varies based on the type of vaccine that you would have had on your primary series. So if you had AstraZeneca or Pfizer as your primary series, your booster dose is expected 6 months after your final second dose of those vaccines. If you had Sinopharm, your booster dose could be anytime 3 months after. And if you had Johnson & Johnson, 2 months after that initial dose. So hopefully that clarifies a little bit. Sure. And if you've done the first booster, the second booster will usually come 4 to 6 months after, regardless of the type of vaccine. So again, it varies a little bit for the first booster. AstraZeneca and Pfizer, 6 months. Sinopharm, 3 months after your end of your primary series. Johnson & Johnson, 2 months after that single dose, and then your second booster comes 4 to 6 months across the board, regardless of vaccine type. All right, I've been asked this, if you have COVID, generally our guidelines suggest if you have COVID to wait 3 months between the end of the infection, or at least confirmation of the infection, and then your vaccine. Right?
Thank you very much, Dr. Parasham. I just want to ask the Minister to speak very briefly on the whole question of vaccine availability and to respond to the question I'm sure would be there. If I did have vaccine of one type, can I be boosted by another type? And how can we mix vaccines? Could you address that?
Thank you. Minister? So let's deal with the second item first. WHO, I think around the middle of last year, CMO, issued an advisory that WHO vaccines are now interchangeable. So regardless of what you got in your first primary series or boosted, if you need an additional booster, the second booster, if you were vaccinated firstly with AstraZeneca, like I was then boosted with Pfizer. If you were vaccinated with Johnson & Johnson, you could be boosted with Sinopharm. So they are now interchangeable. And what we have in the system now are both Johnson & Johnson and Sinopharm. As far as our stocks are, in Sinopharm, we have 244,788. So that's about 250,000 doses. However, they expire in June 2023. Johnson & Johnson, we have 185,286 expiring in May, July 2023. Now, the question is, people always say, I am waiting to be vaccinated. When we brought in the Pfizer pediatric doses, which were expiring in October 2022. In those days, we were having press conferences often. I literally begged parents, go and take your children to get vaccinated because the vaccines are expiring. What I have now are parents breaking down my doorstep to get vaccinated with the Pfizer pediatric. So the message is, don't wait. We don't know what's around the corner. We just don't know what's around the corner. Be proactive. Weigh your personal risk assessment, especially for the elderly, where the virus may come home and meet them innocently. Grandma, grandpa, poor, Aji, Aja. the vaccine may come home and meet them because their children, grandchildren are out working or out socializing. So to protect them, you get vaccinated and take them to get vaccinated. So we have stocks, but they are expiring by the middle of the year, between June and July 2023. Let's not repeat what we did mistakenly with the pediatric Pfizer doses. And now parents are breaking down my door to get those vaccines. Do it now, be proactive. Thank you, Honorable Prime Minister.
Thank you very much. I think this is a good time to open the floor to the media, because I'm sure you have a few questions and further clarification. Will you say more, identify yourself and put your question, please.
I wanted to find out about the updated vaccines which we see featuring overseas and whether our booster shots can line up in terms of, efficacy against the Omicron.
Doc, if you would prefer Professor Carrington to respond to that. And for those, just 1 minute, Professor. For those who didn't hear the question very clearly, the question is an important one. There are new vaccines being made all the time, and they're like spanners with a piece of equipment to fit the variants, and they're out there in some countries. And the question is whether what we have available can do the job as well as, or at all, as compared to the vaccines that are available out there, which are new forms of the response.
Okay, so the first thing I'll say is that the job of any vaccine, regardless of whether it's COVID-19, influenza, dengue, yellow fever, whatever, the job of the vaccine is to reduce your risk of disease, severe disease, hospitalization, death. Vaccines are not designed to prevent infections, okay? They prepare you for an infection, to better battle an infection. So that's the first thing I'll say. So when the Omicron variant emerged, because it was shown in laboratory studies to evade some of the immunity conferred, of the antibodies immunity conferred by previous vaccines, they thought, let us update the vaccine. And Pfizer, I think Pfizer and Moderna did this, and they got approval to make a vaccine that was going to match BA2, that variant, that one of the earliest Omicron variants. By the time they were ready to make the vaccine, we had BA4 and BA5. So they made a vaccine against BA4 and BA5. If you test those, the immunity produced by those vaccines in a laboratory for its ability to block the virus from entering cells, you will find that the BA4 and BA5 vaccines performed better against BA4 and BA5 than the other vaccines. However, when they looked at its ability to prevent severe disease, keep people out of hospital, there's really not much difference between them. So this is real world data, not laboratory data. So while those vaccines may have been better at preventing symptomatic reinfections, the difference between them and the other vaccine protection and previous infections against those variants is not much between them. The last thing to remember is that we have moved past BA4 and BA5. We now have BF7, XBB1, etc., etc. And in the these are not just restricted to, Trinidad and Tobago. So even in the US, XBB1 is the one that is around, and their population has been vaccinated with those bivalent vaccines. And that vaccine against a previous variant is still performing very well. So I don't think it is, there are people who argue that, and I am of that view, that we don't need to be chasing these variants with a vaccine every time. It would be lovely if we could develop what we call vaccines that give cross protection, even against reinfection. And people are working on that. But chasing these the variants it's difficult, and I think that the evidence suggests, and even our data from Trinidad, we've had lots of variants circulating, and the vaccines are still performing well. Okay, thank you.
Thank you, Professor. That brings us to the point, and the answer is we have had a lot of vaccines in our hands. The vaccination program has literally stalled by the time it would have affected the population at 50%. We were at 51%, 51, right? And interestingly enough, very many people who did not take part in the vaccination program might be out front saying, well, you see, I'm here. I didn't need to get vaccinated. That is not an explanation for the vaccination program. The people who got vaccinated did a job for the people who didn't get vaccinated. Because if the population had not been vaccinated, the effect of the virus on the overall population would certainly have been far worse than we experienced. And for those same people in the population that did not get vaccinated at all and who got some level of immunity, naturally, the vaccinated population would have slowed down the rate and spread, and along with the other things that we did. Because basically what we were doing was trying to get the population not to be overwhelmed by the virus, not to have the hospital system overwhelmed by people who needed care and couldn't get it. So that was a management going forward. But now that we've had some breathing space and we have a lot of people vaccinated and a lot of people naturally immune, then we can now make all kinds of comments. Recently I heard a medical doctor, even as we are saying now that with the new variant, and the world is saying, WHO and other countries, like us who are looking to protect our population, being exposed to new variants and saying that, well, what is the big thing that we could do now going forward, even though we do know that we can't escape as we can. Get vaccinated. And if you're vaccinated, get boosted. That is the official policy of the government of Trinidad and Tobago and the World Health Organization. But you do have, I recently heard a medical doctor here in Trinidad on the radio telling people that the vaccines are a waste of time. And naming certain vaccines that don't work and can't work. Now that level of irresponsibility doesn't help. The fact that you have a DR in front of your name does not give you license to talk foolishness. Because there are people who rely on you for information. I'm sure there are different points of views in the medical fraternity, and there are certain basic facts that we cannot escape. And that is, as Professor Carrington has said, the role of the vaccine is to prepare you in the event that you get infected. But you hear people saying, well, if you take a vaccine when you get vaccinated, how can you still get in COVID? That is not the role of the vaccine. And a lot of data is now generated in our population. In fact, our country at 1.3 million people, having done what we have done in the way that we have done it, we are in fact a veritable laboratory. And in entering the fourth year, we can look back with some confidence at what worked and what didn't work and what we are looking for. And that is why, even as Dr. Hines did not show us, I don't know why, the projection. Could you show us the projection curve, please? Because we always show that. If we, what are we anticipating going forward?
Okay, so that slide set didn't contain the projection slide, but what we did see when we looked at the projections moving forward is an increase, a fairly rapid increase in the expected sort of average number of cases per day. So it was 58 at the last update. By the middle of next week, if we continue at the rate that we're going at, the average number of cases maybe in the low hundreds. And the week after that, maybe in the high hundreds. So we know that we will see increases in the numbers of cases, especially as we have more movement, more gathering, more mingling that is unlikely to decelerate. So it's another reason to re-emphasize the need for those who are vulnerable to protect themselves by getting vaccinated, those who know they live with vulnerable individuals and who plan to go mingling and having a good time, to also vaccinate themselves to reduce the risk of infection and the risk of transmission, and to have all individuals in those places where we can have transmission, also take their own personal precautions and protection, wearing their masks indoors in enclosed spaces. All of those things will help to blunt the speed at which this projected rise may actually unfold. So hopefully that info makes up for the lack of the slide.
Thank you very much, Dr. Hines. So the projection on the data that we have, looking from November to December to January into February, with a carnival somewhere in there, over next 4, how many weeks you have left in carnival? The projection is that that curve would steepen. Right? If that same curve was the curve that we were working with 18 months ago, we would have been taking some drastic action, because such a curve would most certainly have overwhelmed the health system. But because of the milder nature, because of the higher level of immunity, we can expect to live with that curve without too much disruption, except in the personal behavior. We're not disrupting the economy, we're not disrupting the border, we are living with COVID, expecting that a slight rise in the level of the population, the level of infection and a variant that is not as virulent. And because we have so many people who are carrying some immunity, we will proceed to live with COVID. Any more questions?
Good day, Rashad Khan, Guardian Media Limited. I don't know if Dr. Hines or Dr. Richards would be the one to...
Please the question, and Professor and Dr. Parasam will determine who will answer.
Okay, sure. So on the point of the projections for cases, we're seeing that within the 2 weeks, we're expecting high hundreds of cases, right? Do we have projections for how many of those would require hospitalizations and even probably result in deaths? Because I know with the different factors of immunity and things now, that ratio of cases to severity would change.
And Dr. Hines will answer that question.
Okay, thank you, Mr. Khan. Now, what we're seeing at present with the current ratio of hospitalizations to average cases in the preceding week is that we're seeing a ratio of about 0.12. It doesn't mean that 12% of the existing or the daily cases end up in hospital on a given day, but we're looking at the ratio of the rolling average of new cases over the week before and what that translates to in terms of numbers of new admissions. We're seeing a ratio of about 0.12. If we project that going forward, then we'll go from single digits in terms of admissions in this week to maybe low teens to mid-20s on a daily basis in the next 2 weeks in the absence of enhanced personal precautions. So again, we are emphasizing that the people who have been admitted in the past, the people who continue to be admitted, are largely the unvaccinated ones. And the people who have fatal outcomes are also the unvaccinated ones. That is something we have under our control, personally, by getting vaccinated and by taking the early steps now, before we start to see the surge, to take personal precautions, get vaccinated, and hopefully blunt even what we are calling as projected numbers going forward. So thank you for giving me the opportunity to emphasize the need to do the preventive stuff now.
Is there any way that we could get actual figures? Maybe at a later time, if you don't have it now, like that projection chart that you usually show?
Yes, of course.
What, in a recent discussion, what the chart was showing, and we haven't mentioned that this morning, is the variant that we're using now, that is in fashion now in the population of COVID variants, is expressing its ability to infect more quickly and a little more effectively. I think that's what the biological data shows. So when you look at the virus and it's locking onto cells, it's doing it a little more efficiently and it's doing it more quickly. And the doubling time, Dr. Hines, you may again, just tell me if I'm right, that when you're looking at the level of infection in the population, is how long it takes to move, to spread, the doubling time. It's faster in the current variant. So it's a good thing that the clinical effects are weaker. Otherwise, we would have been in much bigger trouble if the clinical effects were, say, like Delta, with this kind of better locking on, faster infection, then we would have been in a real trouble. But the facts are that it is infecting more quickly, and that is why we really need to be that personal responsibility that we are trying to emphasize, which is the response that we're calling for today, the personal responsibility. The country is open, but there's COVID out there. Take personal cover. You know what you can do. There are a list of things that you can do. Do those things that you can do, because you can't isolate yourself unless you're a hermit. You don't go out, it comes to meet you at home. There are people who are aged people who never went anywhere. COVID killed them in the home for the aged. Somebody brought it there. Home in your own house, you have grandparents, you have parents, you have people in the family who have comorbidity. You are a threat to them. That remains, that does not change. So we are asking for the personal responsibility. The national program now is to encourage. And finally, before I came down here to Japan this morning, I was going through the countries that are taking action. The one common action that's being taken is the mask. The wearing of mask, especially when you are going to be in close quarters with people, it is helpful, but we still leave that as a voluntary action. But you know, in the personal responsibility that you will take, you know what level of exposure that you will do, and that the mask does help. So if you know you're going to go out there to take part in Carnival, make that decision. It's your decision to be made, whether you will wear a mask or not. But the one good thing is that we know a little more of the virus. We've had 3 years of managing with it, and the situation now does not warrant the panic stations that we had in year one. And we are not as exposed as we were. But that could change if some things change. Yes, Jewel.
On TV6 News, Prime Minister, you did lay out a context in terms of the present overall immunity with regard to Carnival, for example. The projections, I'm wondering, that we would have heard, would that factor, because we are opening, of course, to visitors, and Carnival is a major tourism event, it's being touted as the mother of all carnivals even. With the issue of the number of visitors coming in, would that factor into projections, or is that something you would monitor as visitors arrive?
Well, the spread of the virus is controlled by how people interact. People coming in, the virus is already in, we are mixing, and we are expecting that the virus is getting to a situation where it's like the influenza, you know, we have a flu season, a flu going wrong, and they call it the whatever, give them names, and it goes through the population. Some people get it, some don't. But because of the higher level of infection with this virus, a small percentage of the people who are going to be infected could be severely hampered by it or damaged or killed. And those are the ones that we're trying to minimize on. Because a lot of people, you're here, you've been with the virus. I'm sure you know many people who got COVID and were surprised that they got it, or didn't think they ever had it. And they went for a test and discovered that they had COVID. So COVID has been with us now for 3 years. And we really are a different population to when it threatened us in the beginning, right? So we don't expect any explosion out of Carnival with respect to the demand for hospital care, unless, of course, right, we totally disregard and try to break records. I don't know we're doing that. I think we still have a population that is aware, and with some element of personal responsibility and the fair level of immunity that we've had, but don't be surprised if we see increased numbers. And if the increased numbers become threatening with respect to our ability to provide the care that would be required, then the government will have to act in a different way. But right now, we are being in a precaution stage. Right?
Just as a follow-up, Prime Minister, so it's your hope, I guess the government's hope, that we would not see, again with the all of the context you're providing, what happened after Carnival in 2020, we didn't see no reoccurrence of that after Carnival this year. In terms of having to make those tough decisions, you would have made it after Carnival.
It all depends on what we're dealing with. After Carnival 2020, we were dealing with a different situation. Remember, 2020, we were an unvaccinated population. We had not had chance for national immunity to develop in the population. So that is the main plank on which we're going. It's a different population. Right?
Just want to circle back to something you said and to build on what Joel was asking. So you said that there's no need to institute any sort of restrictions on travel now because the variants they're here already, right? But given what is going on in the rest of the world, particularly China and even in the United States, and considering how much we've benefited from both countries when it comes to vaccinations and even trade, will we have that willpower to institute any sort of restrictions on them should the need arise?
Know your country. Trinidad and Tobago was one of the first countries in the world to have placed restrictions on people coming from China. As a matter of fact, when we did it, the Chinese were a little surprised and inquired as to whether we were confident. We explained our position, and China is a country that we have good relations with, and they understood. But let the record show that very early in the proceedings, when the science was telling us that the infection period was within a 14-day, right? We put a restriction on people coming out of China. Now, the different situation now is that you would have seen some restrictions, not very much, people coming out of China and certain parts of China and so on. But then what about the variant? There is one variant that developed in the United States, which was a Western Atlantic mutant. So those are the things we're dealing with. So even if we shut off one country there, we can't shut off that on the variant that we know in China, when a new variant is in fact the most popular and aggressive one is one that developed in our neighborhood. But the thing is that we are dealing with a slightly different population. That's the good thing. Yes, I didn't knew.
Alina Dudnas from News. Thanks very much for having me.
Thank you.
Quick question. I know that we appreciate our health workers, and there has been mention of gratuity for them. Just some ex gratia payments, sorry, Minister. I've received some information, however, that some of the nurses, there are slightly varying amounts being given. Now, please correct me, but is it that there's a criteria whereby they're required to work for over a year in order to attain this ex gratia? If you could clarify, thank you so much.
Yes. So, first of all, thanks to all healthcare workers. So, the Cabinet note would have approved the ex gratia payment of 1 month's salary. We did do a sliding scale for persons working from 1 month to 1 year. So if you worked for 1 month up to 6 months, you got 25%. And for 6 months and 1 day up to a year, you got 50%. Yeah. Okay. You're welcome.
Paula Linda here from the Newsday. I have a few questions about vaccines, etc. In my case, I have gotten the first 2 shots, AstraZeneca, and then I got my 2 booster shots. My last booster shot would have been in August. Would I need to get another one?
You want another one?
That's an
excellent
question because I have the same question, right? So thanks for asking it.
Well, the guidance from WHO so far is that persons who have had your full primary plus 2 boosters, at this point it hasn't been approved by WHO to go beyond. So far in Trinidad and Tobago as well, we are holding. Our national tag has looked at it, but again, there's no signal from WHO yet to go to a 5th and a 6th and a 7th. In terms of the data coming back in terms of waning immunity and all of that, and of course hybrid immunity with vaccination plus infection. So all of that data has to, of course, reach WHO and they make a final decision, but their tag group hasn't gone beyond a 2nd booster as yet.
My next question question is, considering the projections that that were shared with us, if people test positive for COVID or are waiting to see if they have tested positive, do they and their households still need to quarantine for 2 weeks?
There's still a quarantine period in place for Trinidad and Tobago, so the quarantine period is 10 days. From either, if you're asymptomatic, from the date and time that you have your positive test for release. So there's 2 ways you could get out of quarantine. Either you wait the 10 days, and if you are symptomatic from the date of first development of symptoms for 10 days, or you can have a negative test done anytime after day 5 of your symptoms or your first positive test. So that's the national criteria as it stands. And it's based on Omicron, the behavior of Omicron, and a number of tests worldwide that suggests before day 10 you're not going to get a negative test. And we have seen that in our population as well. So it is really to prevent an infected person going back into the workplace, the school, and everywhere else and spreading it knowingly. So it is a check and balance. I know other countries have dropped their restrictions and gone down below, but there's no change in terms of the way Omicron behaves as yet that we know from the data that suggests that we should decrease the length of time.
Ask for some elaboration on that same point.
Yeah.
So that exit testing criteria.
Sure.
Is it that a patient, so let's say hypothetically I get COVID, after 5 days, am I allowed to leave isolation or quarantine to go to a private institution to get tested?
Well,
you able to get that exit?
I mean, a lot of people would have their testing done at drive-thrus, for example. So we advise if you're known, of course, just for the purpose of testing, you wear your mask, you do what you need to do, you have your test and you return. So generally speaking, that is allowable.
How much reliance can you put on home testing?
Home testing is very variable. What we have seen for self-testing and home testing by way of Omicron, the majority of them that we have seen perform well, meaning they pick up the positives once you have symptoms. False negatives tend to be a little greater of a problem. So, for example, you have no symptoms, you were exposed. The home tests are not as good as picking up very low levels of the virus. But generally speaking, with Omicron, once you have those symptoms on you, the self-tests have performed generally well, the ones that are out there in the population.
So if you are experiencing symptoms and test negative, you can go out and continue your...
By home test?
Yes, by home test.
Depends on the need. I would suggest, you remember, we're not guarding against COVID spread alone. We have a plethora of viruses out in the population. We have RSV, you have rhinoviruses. Before COVID-19 came on the scene, we always advise that people stay home if you're ill. And it's something that we want to continue, especially with school and workplace. You don't want any virus that you have to be spread amongst your workers, your co-workers, your schoolmates, and everyone else. So stay home if you're ill, whether it's COVID or not.
Yes, Joel. This is going to be the last question.
I just wondered, in terms of, just following up on what the CMO would have just said, in the context of going forward, would the government be advancing or continuing to look at the issue for the public service, of course, because that's your ambit, the issue of working from home in terms of reducing gatherings as you look at this variant and the curve as we will see?
This is a case-by-case arrangement, and once the management and the public service can justify what is being done, we would not discourage it. And of course the private sector is free to do as much as they can. But I want to end this morning's conversation with the public through you, the media, by saying that we have a responsibility at the personal level, at the household level, at the workplace level. We are still in a pandemic. The pandemic can cause people to still die and many people to be hospitalized from reactions that are quite unpleasant. So what we're trying to do is to, if we can't eliminate it, which is quite difficult, we try to ameliorate it. We try to suppress it. And we also don't go with abandon encouraging infections under the understanding that nothing ain't gonna happen. Something could happen, especially to some cohorts of the population. We know that we're having carnival. Carnival is a situation where a lot of people would mix. we would still expect that you would keep that at the back of your mind and take your personal decisions. I want to end on the note today that in 2022, January going into February, we are managing COVID by 2023. Sorry. My apologies there, 2023. We are managing COVID largely with a serious input of personal decisions for protection of yourself, your associates, and the wider national public. The state protection is there. The hospitals have worked well. Our health staff has done extremely well, and we're hoping that they're never called upon to do what they've done in the last 3 years, because it was mentally and physically draining on them. And we do have some vaccines, and we will, if the demand is there for more vaccines, vaccines are now a little more easily available. And since they're interchangeable, we have a couple 100,000, we have almost 400,000 vaccines in hand. So there's no question of vaccines not being available for a while. But if we do see a demand, we will then respond to that. The population, which is a different population to when we started out, take some element of responsibility. Thank you very much for your attention and your cooperation.
The winning numbers in the National Lottery online.
WESN